see some familiar faces in the meeting, as well as some new ones. For those who don't know me, I'm Peter Seibotham. I'm a panel member and a paediatrician by background, and it's really good to be with you today for this webinar, and recognizing that this is an interesting but challenging area of how do we deal with bruising in non-mobile babies, and recognizing the very real risks around that, while at the same time not wanting sort of knee-jerk reactions that in themselves can be harmful. And the more we've sort of started looking into the more we've realized it's not a straightforward issue for safeguarding partners, health partners to deal with, but also within that wider multi-agency framework. And so it's been an issue that's been on our mind as a panel. We did some work last year with some round tables and further consultation, and put together a briefing paper. And we felt it would be good to have this webinar to allow people to reflect and discuss some of the issues that we raise in the briefing paper, and to think through a little bit more how you might take things forward locally. And we're very keen to hear from you also in terms of what we can do nationally to support you, any changes and developments that we can take further. So just to flag up what's the panel role in this. Sorry, I'm going to try and make sure I can see the slides as well as the meeting. Okay, so the panel, as you're probably aware, is an independent panel. We're made up of individuals from a range of practitioner backgrounds representing the key agencies involved in safeguarding children, and including the third sector within that. And we have a role in terms of an oversight of the whole system of learning from serious cases, oversight of the system of national and local reviews, identifying lessons coming out of that may have a wider implication beyond the individual local safeguarding partnerships, as well as through our national reviews, and recognizing that we're in a position with connections both to practitioners and managers on the ground, but also the other way to government departments, other bodies and so on, that we can have an influence. And we take that responsibility seriously in trying to use our influence to help improve the safeguarding system within our country. Now, injuries and harm to children under 1 makes up a significant proportion of what we see as a panel. And you'll see here data from 2020 and 2021 of, on the left-hand side, the number of serious incident notifications made each year, and that does fluctuate year on year, but is around the 400 to 500 notifications per year. Of those, in the second pair of bars, around about a third are notifications involving infants under a year of age. And of those, a significant proportion will be non-fatal physical abuse on the right-hand side, and then very small numbers of fatalities related to physical abuse. But all of those are really significant, and if you combine the fatal and the non-fatal physical abuse, you'll recognize that that makes us a substantial proportion of what we see as a panel in terms of notifications of serious harm to children. Now, we started looking at this issue of what do we do in relation to non-accidental injuries in the under 1s. And as we reviewed some of the cases that had been notified to us, we saw this sort of dual pattern of some serious injuries just appear to present out of the blue. So serious injuries without prior presentations. And I've just given 4 examples here. A 12-week-old baby presented with fractures. There had been no prior concerns at all about this baby or their family. A 4-month-old, serious injuries inflicted by the father. There were known parental mental health problems, but no previous presentations for this child until a nursery nurse picked up that there were bruises on this baby and followed through their bruising protocol. A 3-month-old presented with bruises, no serious injuries in this case, but a large number of bruises. And again, in this child, there had been no prior concerns. And then an 8-month-old presenting with multiple injuries and at the same time identified concerns regarding neglect, but there had been no prior injuries to this child. So those are some examples of infants who suffer serious harm without having previously presented with any indicators of physical abuse. On the right-hand side of this slide, you'll see a number of cases where there were serious or fatal injuries and there had been previous presentations. So a 10-month-old with fatal physical injuries, issues around neglect, substance abuse, poor parental engagement. This child had presented a month previously with a bruise to the forehead. A 10-month-old, fatal physical injuries, a context of domestic violence, again had presented previously with a facial bruise. A 2-year-old with multiple bruises, and this 2-year-old had previously had 14 ambulance calls because of injuries. So a large number of injuries of this child, and then the more serious incident that triggered the notification. A 4-month-old presenting with multiple injuries had twice presented previously with bruises. 13-month-old with abusive head trauma, previous concerns relating to neglect, domestic violence, parental mental health problems, and this child was on a child protection plan due to multiple prior injuries. And then finally, an 18-month-old, fatal physical injuries, known parental mental health problems, and one previous presentation with an injury following an alleged fall. So you'll see we get both sides of this, the babies who present without prior concerns and those where there may have been previous presentations with injuries as a precursor to a more serious set of injuries or harm. Probing into this a bit further, we recognise that there was a degree of confusion and ambiguity around how local health partners and multi-agency partners responded to the issue of bruising in premobile infants and the protocols that were in place. And just to give sort of a couple of examples of the breadth of what we saw looking at the guidance and the protocols that were out there. So this first one, research and serious case reviews confirm that relatively minor bruising may be a warning that an adult is under stress and or that a baby may be at serious risk. A lower threshold for referral for both medical and social investigation is needed to effectively protect a baby or a young child. And then secondly, a bruise should never be interpreted in isolation, must always be assessed in the context of the child's medical and social history, developmental stage, and the explanation given. And we saw a complete spread here, right through from those that said, if a baby presents with a bruise, there must be a medical assessment and the medic must judge whether to take it further or not, right through to those that say any baby presenting with a bruise, it should trigger a Section 47 child protection investigation and a child protection conference. So that sort of big spread of professional judgment, decision making, and so on. With the cases that we were looking at, both rapid reviews and local child safeguarding practice reviews, we saw a range of examples of different learning points, recommendations, and good practice, as well as areas for improvement of practice. So again, just to highlight a few examples of this, recognize that in some cases it may be appropriate for the initial practitioner who identifies bruising to seek medical advice. So quite vague. Where do you go with that as a protocol? It's leaving a lot of ambiguity there. The bruising pathway has been updated for the hospital and is in the process of being reviewed and updated for GPs. So a clear recommendation, action to take that forward. Complete a review of all policies and guidance to strengthen how professionals analyse the context and circumstances of the bruise to a non-mobile baby. On the right-hand side, the failure to act in accordance with practice guidance on bruising in babies and children replicates similar themes that are currently included within a child safeguarding practice review. Serious concerns that this is another case involving a baby with an injury where the immobile baby bruising protocol and pathway was not followed. Need to follow an agreed pathway for bruising, marks, injuries in the immobile baby. So what is the evidence? Well, we went back to some of the source evidence of this, which is quite nicely summarized in the Royal College of Paediatrics and Child Health Child Protection Evidence Systematic Review of Bruising. And of course, there are other issues in this, not just bruising in pre-mobile babies, but what do we do about patterns of bruising? What about bruising in disabled children? Bruising in children of other ethnicities and skin colors, bruising in older children. There's a whole range of different issues here, but specifically looking at the issues around pre-mobile babies, you'll see from this slide that most of the studies seem to be suggesting a low prevalence of bruising in pre-mobile infants. So Pierce 2016, drawing on pediatric emergency departments, found a prevalence of non-abusive bruising in pre-mobile infants of 1.3%, and that's fairly typical. Kemp, one of the largest studies in this country, using well baby clinics, mother and baby groups, in those babies who were not rolling, a prevalence of 1.3%. In those who were rolling, that goes right up to 11%. Sugar, 99 in the States, well child clinics, prevalence of 2.2% of non-abusive bruising in pre-cruisers, going up to 18% in cruisers and over 50% in those who are walking. Carpenter, similar time, again, similar sort of figures, 3.9% in those who are sitting but not crawling, going up to 17% in crawlers, 37% in those who are walking, and then Edgewood, 25% in those who are cruising. So that's some of the spread of different research studies talking about the prevalence of non-abusive bruising in pre-mobile infants. So on the basis of this, the National Institute for Clinical Excellence advised that health practitioners should suspect child maltreatment if there is bruising or petechiae that are not caused by a medical condition and if the explanation for the bruising is unsuitable. And they specifically mentioned bruising in a child who is not independently mobile. And where a health professional suspects child maltreatment, then they should refer that child or young person to children's social care following local arrangements. But how do we then interpret the current guidance and evidence? It seems very clear that bruising is the most common injury in children who have been abused, but it is also quite a common injury in non-abused children. Children get bruises, okay? And the exception to this being pre-mobile infants where accidental bruising is rare. And the number of bruises a child sustains through normal activity increases as they get older and their level of independent mobility increases. Now that's all very sensible, straightforward and clear. However, if you start digging a little bit deeper and going back to those studies and what they were actually reporting, the Kemp study, the large study from the UK, identified that 5% of pre-mobile children had a bruise at first examination. So no suspicions of abuse, accidental bruising, okay? 5%, 1 in 20 pre-mobile children will have a bruise at any one time. And 27% of their pre-mobile children had a bruise at some point over a 12-week study period. So maybe it is not so rare for babies, including pre-mobile babies, to sustain bruises without there necessarily being any concerns about abuse. And Andy Bilson, a professor of social work, has looked into this further, and he concluded that at least 1 in 20 infants will have non-abusive bruising at any one time, and over a quarter could have bruising at some point during any 8-week period. So that was drawing on the same evidence that had informed the NICE guidance. So certainly his concern is that we don't overreact and end up over-intervening when actually there aren't concerns about abuse. Balance that against the very real evidence that we see in the panel that some children present with serious injuries and have previously presented with bruises. So somehow we need to get that balance right, and that's what I sort of really want to put before you for further discussion. So what we did with our briefing paper on this is we made a number of recommendations. First, that the NICE guidance on bruising should be extended to all professionals, not just health professionals. We think it's really important that there are very clear definitions of what we mean by pre-mobile. So a child who is unable to move independently through crawling, cruising, or bottom shuffling, and distinguishing between those who are able to and those who are not able to roll over. In all cases of bruising in children who are not independently mobile, there should be a review by a health professional with appropriate expertise and a multi-agency discussion. But we are not recommending an automatic Section 47 investigation or other interventions without that initial appraisal. We advise safeguarding partners to review their own current policies in the light of the current evidence and guidance, and we're recommending that the Department of Health and Social Care, NICE, and the Royal College of Paediatrics and Child Health should review current evidence and guidance. So I expand on that a little bit in terms of recommendation 3, but I'm going to skip right now to the questions for discussion so that we've got time to talk that through in our breakout groups. And Steve, you might want to say a little bit more about the process of this. But I'm putting out these discussions, particularly want people to focus on that last question. How can we appropriately balance the recognized risk to pre-mobile infants with the risks of over-intervention? Steve,
thank you, Peter. Yeah. So, Peter, just before we go there, there's just 1 or 2 comments that we've picked up in the Q&A. Excuse me. There was a question about number 6, which is about higher social class, and is that a reason for better masking or hiding injuries? And a comment saying, I wonder if this is the case. I've also found that those of a lower social class whose children are open to social care, however, all children are at risk harmless regardless of social status. There was a comment about the capacity of services, of course, to look at the full history of the child and the family, especially if they present in primary care. It must be remembered that this only represents cases that come to the panel rather than all cases. I think you made that point, Peter. Comment about some of the professional terms, such as rough handling, not being helpful, not specific enough, and potentially underestimate the impact on the non-mobile child. There was a comment about the role of doctors, which is number 12. I found a complete difference in understanding of the report by named doctors regarding when a section 47 should be triggered. It appears doctors still believe it should be in their judgment whether they make contact with social care. Peter, just a few kind of responses to those issues. I know we'll cover them in the breakout
thanks.
as well.
Some really important points there, and I think highlights some of the challenges inherent in this. In relation to social gradients, we recognise that there is a very clear social class demographic gradient in terms of serious and fatal harm to children, but balancing that against the reality that any child could potentially be subject to abuse, and absolutely right that as professionals we do have those inherent biases, that we tend to trust educated, articulate parents more, and I think we need to hold that level of skepticism. I think the issue of professional judgment and balance is really important, and that's what I really want people to focus on a bit in the discussions that you have in your groups. I think there is a challenge here. We could easily get overwhelmed by trying too hard to over-investigate every single concern. And so we do need to have some professional judgment. We do need to appraise the whole circumstances of the case and make decisions based on that broader concept. And that's why within our recommendations, we've emphasized that any pre-mobile child who presents with bruising should have a review by a health professional with appropriate expertise to assess the nature and presentation of the bruise, associated injury, and to appraise the circumstances of the presentation, including the developmental stage of the child, whether there is any evidence of a medical condition that could have caused or contributed to the bruising, or a plausible explanation. And that then should lead on to a multi-agency discussion, not necessarily going down a full Section 47 assessment, but at least that discussion to get that broader picture, because of course the medic who sees the child will only have a small part of that whole jigsaw. So I think I'll just leave it at that and maybe use that as a springboard to go into our discussion points. Certainly those other comments in the forum, I think really important, and you may want to pick up on those in your groups and add them in as we go along.
Okay, thank you, Peter. So very shortly you're going to be put into the breakouts, and the forum screen will change. I've noticed there's about 5 or 6 of you who haven't made it to the forum yet. Do let me know in the MS Teams if you're having a problem with that. But what you'll now see on your screen is the 4 topics in the different colors. You simply click enter in the bottom left to get into the first one. I'll bring you all into that right now. And so please focus on this question, but perhaps tackle at least one of the other questions. And I think when you get to your breakouts, have a quick discussion about what the priorities are for you, or where you think the work to do is, so that you prioritize your 15 minutes we're going to spend in breakouts to really think through the issues, share your perspective, share your insights, and potentially any good practice that you know works around these issues. Excuse me, and capture it. So it doesn't need to be the author of the comment who captures it. It could be anybody in the group. So please make sure that you're adding as much, capturing as much as possible in the forum, because once we're out of the breakouts, the nuance and the detail of what you've been discussing may be lost, and we want to ensure that that's available and shareable with the rest of the safeguarding community. So that's how you do it. You can click through the other topics, so cover at least two topics, but focus on the first, which is how can we appropriately balance the recognized risk to pre-mobile infants with the risk of over-intervention. And I can see people are already adding in there. So Amina's, I think, ready to put us into groups. You'll be with between 7 and 9 colleagues. Excuse me. There will be a facilitator in each of the groups. They'll just break the ice What I also suggest you do is, as you speak first, just say who you are and where you're from, what your role is, so that people know what perspective you're speaking from. And we'll see you back here in about 16 minutes. Thanks, everyone.